welcome everyone to the Performance and Audit Committee of the 29th of January. So just to note that the Fresh are in attendance today, and or will be.
So yeah, he's not here yet, Bob, but he might join yet. Yeah.
Okay, thank you very much indeed. So I'd like to welcome one of our other colleagues who's here today, Colleen Carlton, who's one of the board members, and she's joining today as an observer. Thank you very much indeed. Hi there. And there aren't any other visitors today that I'm aware of. So I'm going to go straight on to the next section, which is about any declarations of interest. Thank you. And that takes me to item 3, the minute of the previous meeting and the action tracker. Could I take any comments on the accuracy of the minute before I move to approve? Any comments? Okay. I'm now going to move to approve the minute of the meeting of the 20th of November as a correct record. Thank you. That now takes me on to item 4, which is the Dundee Health and Social Care Partnership Performance Report 24-25 Quarter 2. Who's going to lead on this today?
I'll be speaking to it with the help from Angie Smith.
Thank you, Shahida.
Okay, so the purpose of this report is to give the key messages on the performance of the national indicators, the MSG indicators, and the social work data. So I've been asked to keep this brief, so it'll just be a brief summary of the report. So most of the indicators are for the rolling year, October 2023 to September 24. So we have been, for this report, we have used 2 baseline years, 2019-20 and 2018-19. And this is because 2019-20 baseline could show possible interference because of the pandemic. So the data in the report compares with both baseline years. So for the key messages in the data, it's worth noting that there are variations in the inequalities between the 8 LCPPs in Dundee. So performance remains poor for emergency admissions, 28 days readmission rate, and hospital admissions between the baseline years 2019-20 and 2018-19. Emergency bed rate is poorer against the 2019-20 baseline year, but an improvement against the 2018-19 baseline year. A few of the LCPPs are showing improvements with North East having the worst performance. So comparing the current data against Dundee, Lockheed has poorer performance for emergency admissions, bed days, readmissions, and hospital admissions due to a fall for over 65s. So both the delayed discharge indicators for standard and code 9 delays show a decrease or improvement. Please note that there are small numbers involved for the code 9 delays, and some of the LCPPs can show large variation because of the small numbers. So Maryfield shows an increase for standard delays against the 2019 baseline and the 2018-19 baseline. So now going to the social care demand data, which is a snapshot date for 2nd of December. 0 people waited in hospital and 118 waited in the community for a social care assessment. 11 people were assessed and waiting for care at home packages in hospital, 163 hours yet to be provided. 18 people were assessed and waiting for care at home package in the community, 20 hours yet to be provided. And finally, I just wanted to mention indicator 17, which was a percentage of care services graded good or better. So that was 77.5 in 2023, but I just wanted to mention it because there was a mistake in the graph, and we'll update it for the next time we report.
Okay, then, thanks. So is that your presentation, Shahida?
Yeah.
Thank you.
That's
You're
me.
ready to take
Yeah.
questions. And I welcome Liam from the Courier to the meeting now. Thank you. Just to say, I should have done the action points, so I'll come back to that when we finish this item. Okay. Any questions for Shahida and Angie? I'll take Dorothy.
I had a number of questions on this report, but Angie has very kindly responded to them for me. So I've nothing more to say this morning. You'll be glad to hear.
Thank you. Any further questions? It's quite a detailed report, and there was just something that I picked up. If I'll take David first, and then I'll come in. David.
Yeah, thanks, Bob. Sorry, I'm just letting you know. My Wi-Fi is playing havoc this morning, so I keep losing you, and you keep freezing. So, just on this one, I hope we're on the first main topic. I'm looking at page 31 of the papers. Sorry, 31 of this report. And it's looking at the number of people waiting for social care assessment in Dundee City. We are on that report, Bob.
We are on that.
You started talking, and I was being.
That's okay, David. You are
great stuff. Yeah, just that. Yes, thanks. Yeah, I was just looking at the chart 1 there, and it's more an observation clearly that how steady that is effectively over the last year or so there, but it's probably an observation, as we know from our discussions in IJB as well, that it's likely that graph is probably only going to get worse as a result of the 25-26 budget, I would have thought, and the demands on social care. So, because I think it was alluded to that, that people waiting for a social care assessment, the length of time that is going to take is going to increase. So I would think that graph is going to sadly decline in 25-26. So it was a first real.
So I see you've frozen again, David, but I don't know, Shahid or Angie, do you want to make any reflection on that? I think it's anticipatory. I can hear what David's saying. But we don't know yet. So I suppose that's the only thing I can say, what you could make that on. Dave, do you want to just say something like that?
Yeah, no, Angie, will you want to come in first? I'll let you come in first.
Yeah, happy to come in. Yes, David's quite right, Bob. Unfortunately, the budgetary position does mean that we cannot sustain this. Although we are still reporting an unmet need at this point, the reality is that is not actually, in fact, an unmet need, because we're providing around 300 to 400 hours a week, every week, of new packages, which covers the small number of hours that are sitting listed as unmet need. Unfortunately, as we have to tighten the purse a little bit, that is going to increase, and we will tip into a bit where there is genuine unmet need in Dundee.
I think for the minute record, I think I would want that to be highlighted, please. Thank you. Dave.
Yeah, I mean, just follow on from that. I mean, that's obviously something that we'll discuss in our kind of the budget discussions in terms of impact and what the implications will mean around that. And I think there is something about kind of recognising that for a number of performance areas that that we are not going to be able to maintain the good performance levels, and that's something that we can, in terms of our communication with the public, we need to be quite clear about.
Yeah, absolutely. And I dare say this is something that will get elevated when we come to discuss this at the IJV itself. So you might want to talk about how you might start to communicate some of that stuff in advance. Thank you. There are some figures that just feel intractable. And Dorothy, did you want to come back in again?
Yeah, just to say we have touched on this at the budget development sessions, and hugely concerning. And I think I've asked previously for some modelling to be done. And Angie has very helpfully given us examples of, you know, if we cut so much out of that budget, what that will actually mean on the ground. And I think that's really important before we come to any decision on the budget, is that we know who this will affect, how many people this will affect, what groups, you know, these well, you call them savings, I call them cuts, will affect. That's really important information. It's not always all encapsulated in the impact assessments in the detail that I think we need to make an informed decision at this budget setting.
Mm-hmm. And perhaps that means that we need to put a bit more granularity into the impact assessment. It would be one way around about dealing with that. Thank you. And I continue to look at table 3, and you know, there are so many quite depressing statistics in there about where we sit in terms of Dundee City across by comparison to other parts of Scotland. And you know, I think there's something fairly majorly strategic when you put all of these things together and how these can be addressed. And I think some of them are a much bigger agenda even for the IJV. So that there's something there that needs to be thought about. But there was just a bit here in Appendix 3, and I think that's electronic page 38, which was about target setting reviewed since 24th of November 2020. So what sort of targets are you anticipating in that?
Apologies, Bob, I'm struggling to find the numbers on the version that I've got.
Is it the big page number at the top right? What number have you got that, Bob? In terms of what number?
It was EFI. It's electronic page 38. Again, because that's how I can find things. I'm looking at 3 screens.
Is it appendix 3?
Yeah.
34.
Page 30, big page 34.
If you say so, I won't find it now. It was about target setting, and I don't know whether maybe it's a question that's not worth addressing at the moment if we can't find it. But as I say, there are quite a considerable number of pages to go through, so I have to just refer to what I've got written in front of me. Maybe we'll just come back to that. Dorothy.
I find I did actually have a question on page 34 on the data sources. In the first paragraph, it tells us that data is currently not available for 8 out of the 13 national indicators, and that the Scottish Government and Public Health Scotland are working on the development of definitions and data sets. Now, my feeling is that these have been missing for some considerable time, and I wondered if there was any timeline that someone could tell us about for these definitions and data sets to be agreed.
Lindsay, do you want to come in to answer that question?
Sure, that's great, thank you. Yep, there are a number of indicators where the development seems to have fallen off the radar of Scottish Government, and either the indicators have not been progressed or the data is not available, particularly since COVID for some of the indicators. The data just has not been available to us, and we simply report what we're provided, and every opportunity we have with our communication with Scottish Government, we do try and keep informed about what their intentions are, and so far there have been no intentions to further develop or provide that data to us.
And I suppose it's a question I'd put back to Dave, Dorothy, because he has more regular meetings with Scottish Government officials. Dave, is that a point you just want to maybe just take up again and see whether we can advance some of that?
We can take that away and see what influence
the Chief Officers Group
maybe make on it. Yeah.
Thank you.
And in the absence of any further questions, I'm going to just go back to the recommendations 2.1 to 2.4. Do we accept the recommendations within the report? and just give me a nod of a head will do fine. Thank you so much indeed. And as I said earlier, before I move on to the next item, I had David, I had actually missed the action tracker point, so you didn't miss anything. So could we just go back to the action tracker point, item 3V for sign off? Is there anything we need to raise in regard to these, Dorothy?
Just an observation, really. This is really short, isn't it? We don't seem to have many actions, and the ones that we've got are all either in progress or completed. I don't know what that tells us about the work of the committee, if it tells us anything. Are we not scrutinising enough, or you know, is everything so wonderful that there are no actions to be taken forward? It concerns me a little. Anybody else got any comments on that?
Come in on that, Bob.
As chair, it's an interesting one, isn't it? Because actually there is quite a lot of scrutiny, but it may not necessarily require action tracking. But anyway, Dave.
Yeah, so no, I get Dorothy's point. I mean, I think I'm quite pleased to see it a kind of small list, because it used to be kind of quite a big list and a lot of kind of actions outstanding. So we've kind of pulled through kind of quite a number of actions and finished them off there. I think, Bob, the action tracker kind of was set up because there was a number of kind of other things falling out of the reports themselves that it was felt weren't being kind of reported back to committee members. So I think for me, it's either we've kind of the reports themselves are kind of providing you as members with more of the information that you need at the time, rather than having to kind of supplement it, or we've been able to kind of answer more of the questions in the meeting rather than kind of taking things away for further reflection. So, but again, no, the action tracker will remain, and Arlene will continue to pick up any additional questions that arise, or areas of further scrutiny as required. But so I can understand your point, but I'm slightly more pleased about it than you might be, Dorothy. So.
Yeah, I think that's so too. David.
Yeah, I understand where Dorothy's coming from on this one, but I think we don't want to have many of these, because it does show that things are being actioned a bit more promptly. And I think because there's so much cross-reference between, with all due respect, the Performance and Audit Committee on the Health and Social Care Partnership and what we read about in the IJB papers, that there's less and less of it being, that there's more and more being addressed in the papers and the reports, as Dave Berry says, that it doesn't mean that we're scrutinising less, Dorothy, because I know I think we're pretty much all over this, you know, and people with a lot more experience than me. But I think really, I think it's more a sign of the fact that there's more satisfaction being addressed already in the papers, rather than us having to. Quite often we're commenting on things in the papers rather than actually raising questions that need answers that can't actually be answered at this meeting in itself. So, but you know, you're absolutely right to raise that point, I think.
Yeah, thanks very much. So it is a compliment to the paperwork as well as the question that goes on in the session. So I don't really want to add much more to this particular item, but I must say I'm quite pleased there are much less actions. And just a final point in that, of interest, see what audits say at the end of the meeting, is sometimes there are some action points that are far more important than others. So there's something about what are the added value of certain actions. So I think there's something about that area that we need to be maybe clear about when we're giving direction back to the Health and Social Care Partnership. Okay, thank you so much indeed. So we note these, and that now takes us on to item 5, which is the Dundee Health and Social Care Partnership Clinical Care and Professional Governance Assurance Report. Who's going to speak to this today?
It's myself, Bob. Thank you. It's Angie.
Okay, Angie, thank you.
Okay, so we present this report with reasonable assurance for the reasons outlined in section 2.2. There is a new group that's been established that sits between the CCPG R2 group that David Shaw chairs and the Clinical Governance Committee at 9 Wells. So the Tayside Clinical Governance Quality Assurance Meeting, which may be renamed going forward, but we're waiting to hear, that's been established to provide strategic oversight, governance and assurance of robust, accountable clinical quality and safety arrangements across all healthcare services. It's also to start looking at patterns and see if we can match across different services where there's trends. Section 5, around risk. The risk profile remains unchanged since the last report. Work continues with all risks to ensure mitigation, management of all risks across the partnership, and the current financial pressures across the system are likely to be reflected in the risk profile over the coming months. So it's just to raise awareness of the likelihood of that. Section B5, the table, there continues to be very good engagement with the CCPG group, with the table at section B5 showing this. The two areas that have been unable to fully comply have been linked to staff absences, and they've been short-term in nature, which has made it difficult to provide alternative representation. Section C, around adverse event management. There are no significant concerns with regard to the adverse events coming into the partnership. There are no clear patterns or themes emerging for any one clinical area, with the quality of reviews of adverse events improving across the partnership. This is providing comprehensive detail of the event, the actions taken after the event, and the steps taken to prevent reoccurrence. The educational events held through the partnerships forum and the support from the governance huddle have supported this and will continue to support to improve quality across all elements of the partnership. The one area for improvement that remains outstanding is in section C14, the overdue verified events. Again, due to vacancies and staff absences, this hasn't progressed quite as quickly as we would like, but we are making progress. If there's any questions.
Thank you very much, Angie. It's a very comprehensive report and there's so much detail in this. Dorothy.
My apologies, first of all, to Lindsay. When I said earlier that Angie had answered my questions, that was a different report. This is the report that Angie has given me a comprehensive response to some of my questions. The one thing that for me is still outstanding is on page 39, which is 5B, workforce risks. I referred to the tables earlier in the report that give risk exposure ratings, and I find these quite useful as a sort of at a glance, where are we with this risks? But there was only a narrative on workforce risks, and Angie has explained that this risk covers a number of separate risks. But the effect of just having a narrative on this means that I'm still not clear where risks stand and how they've changed over time, and whether the mitigations that are put in place to address these risks are working, if you can understand what I'm meaning here. And I know to add another 13 risks in 13 tables would make the report unwieldy, but I just still don't really have a handle on where, what these risks are and how serious or not so serious they are.
Angie, do you want to address that question before I bring in Siobhan?
Thanks, Bob. Yeah, thanks for that, Dorothy. Yeah, I'll pull together something that gives a little bit more detail for the group after this meeting, and we'll try and make sure that going forward there is at least narrative that shows that trend and the levels of risk across the 13 risks that are in the system at the moment. We are trying to collate that into a cohesive single risk, because the risks are very, very similar across the piece, but that work's ongoing.
That would be very helpful, Angie. Thank you.
Angie, do you anticipate that as being in a further update report or as a separate report?
It would just be a very brief narrative for the group that gives a bit more clarification on that one specific element.
Okay, thank you. I'm going to bring in Siobhan.
Thank you. I'm just looking at section A2, and where you say, you know, 3 of the top 5 risks sit within the Dundee Drug and Alcohol Recovery Service, the DDARS. I'm just trying to kind of maybe unpick a little bit of what you said there. Obviously staff turnover has been an issue, but that looks like that's kind of resolved itself. But obviously there's continuing high levels of complex needs. I suppose my question is, are we hopeful that this might settle a little bit in terms of risk?
It has already reduced down in the recent periods. So if you look at the risk exposure with no controls, that was sitting at 20, 25 and 20, which is significantly high. They have very quickly come down to 16, 15 and 15 for the bottom one. So they are heading in the right direction, and there is further work to do, and we hope that that will be further reduced in the next 2 to 3 months.
Thank you. Is that work involved in staffing, or is the staffing settled, do you think?
I don't know if Jenny wants to come in on the actual detail. Yeah.
Jenny, you're on mute.
Hear me now?
Yes. Jenny, please.
Yeah, no, the staffing for me no longer stands out in terms of the levels of turnover or vacancy. I think what we've got though with the service, and I'm a bit loath to go in heavy-handed on this, is an anxiety around things not sustaining. Yeah. So my opinion, they're probably slightly overstating some of the risks, and they have come down, but they've been so long in that position that it's difficult for them to mentally get to a place where they feel secure in it. But it doesn't stand out for me at all in terms of staffing. I've got areas that I'm much more worried about in terms of staffing levels than DDARS.
Okay, thank you. That's really useful. Thanks.
I think this probably comes back, Jenny, to the kind of initial narrative on the front sheet of the document, that maybe it's like highlighting exception, whether it's positive or needs to be strengthened. That might answer some of these questions without us continuously revisiting them. David.
Yeah, thanks, Bob. Yeah, my question really is further on in the report. It's not involved with risks. It's actually, I think it's on page 15 and 16 of the paper. It's learning from complaints, and you might be yourself here, but it's when we're starting to talk about the last sentence in D3, where communication has been circulated to primary care, advising referrals for anti-obesity medications will not be accepted. Is that forming part of a number of the complaints, the fact it's been referred to in the paper? Is that a major part of the complaints? The fact that referrals are not being accepted on.
Apologies, I don't have further information, and I will need to find out and come back to you.
Okay. Yeah, I think the other observation was as well, just I found the page now, I've lost the page, was again on absence levels causing extra workload for others in here, but we're seeing that everywhere in the NHS.
Unfortunately, that is an issue. However, we do seem to have reached the peak of the post-pandemic absence levels around about July last year, and we are still heading in the right direction with the absences.
Good. That's good to hear. Thank you.
Yeah, that's Angie. That's excellent to hear that. There is. I'm just thinking about the complaint side of things, and isn't there also perhaps a role for care opinion update that would perhaps address some of these issues and how we respond to complaints and utilise that service? I noticed that we have a gap looking at the development sessions that we have, so perhaps we could maybe fill that up into one of those vacancies that we have in future development sessions with the full IJV. Because I think there is an issue about complaints, which are also very positive in terms of helping us to strengthen the service as well as to note and progress as well, because it isn't always black and white, I would have, in my experience. Anyway, that's just thought. Right. Thank you. I don't see any more questions on this. Can we therefore accept the recommendations, to note and accept the recommendations within this report?
Agreed, yeah.
Thank you. That now takes me on to the next one, which was referred to in the last page, which is item 6, drug and alcohol services indicators, Q2. Who's going to lead on that?
I'm happy to make a start to this and then pass over to Jerry for any further operational updates, if that's okay.
Thank you. Okay.
Great stuff. Thank you very much. So this paper is to update the pack on the performance of drug and alcohol services at Q2. So performance, it was similar to Q1 for and the data for non-fatal overdose incidents. Percentage of people referred to services for drug and alcohol use who began their treatment within 21 days of referral, which is the national standard, and also the number and rate of emergency admissions. So nothing specific to say on those indicators, very much similar trend as to what has been seen. There was a reduction in the referrals to alcohol treatment in Q1 and 2, and we did note that was, we use rolling data in our performance reports in order to give that strategic long-term directional trend. The narrative suggests, though, that the Q2 standalone performance is showing an increase. So this is where the long-term strategic trend is actually not given the actual quarterly performance for that. So that is a positive, that the narrative is telling us that it's increased at Q2, and we should be able to see that clearer in the rolling data for Q3. The number of people starting alcohol treatment is low compared to the number of people starting treatment and the number of referrals to drug treatments, and the number of people starting drug treatments is increasing. That's all that I wanted to say in terms of what stands out. Happy to pass over to Jenny for any operational updates and answer any questions.
Yeah, I'm hoping that there'll be a good read across in terms of some of the actions that are in progress and some of the data that Lindsay's referred to there. I'll not recite everything that's in the report, but just to draw your attention to work that's underway in relation to our ketamine, alcohol and cocaine pathway work. And we have some work underway to look at the next steps in relation to harm reduction measures, which I know has come up in terms of us being asked to look at things like safe consumption rooms. So that work's underway. And just to bring to your attention that the community detox pathway for alcohol is now up and running, which should start helping with some of the issues and waiting times around that, and gives another option for people who would find it difficult to be in an inpatient setting for a detox. Happy to take any questions.
Martin.
Thanks, Chair. I want to go one question about this paper. I have to say this paper, it's been well written, it's got a lot of good information, but item 7.7 in relation to the safer consumption facility. Are we expecting to receive a paper on that at the IGP, or is there anything that can be updated on that?
So we will keep you up to date on that. That's actually work that's been commissioned through the ADP. So in the first instance, what we've been tasked to do, and I'm sorry, there's somebody appears to be trying to get into the meeting that's popping up quite regularly. What we're doing in the first instance, Martin will be taking a report back to there, making some recommendations in terms of the next steps in relation to harm reduction, which may or may not be a safe consumption room. We need to make sure that whatever we do targets the pattern of use that we're seeing in Dundee and will actually help in terms of harm reduction.
Okay, thank you.
Okay, and Dorothy and then David.
Thank you. I have a question on indicator 4 in the table, which is page 71 of my bundle. And I think Lindsay's referred to this in her remarks. The number of individuals starting alcohol treatment per quarter, and the comment says this is remaining low relative to the large number of treatment starts at the end of 22-23. Do we know why this is remaining low?
I don't. I can look into that further for you. What I would say is what we're starting to do is look at the whole of our alcohol pathway, and that's an opportunity to get into some of the detail of that. The one thing I don't think it suggests is that we've got less people, less need, if you know what I mean.
Okay, thanks, Jenny.
Okay.
There's a high level of disengagement that's worrying as well.
Yeah,
So I
I've seen
think
that in
it
earlier
is-
reports.
It's something that we need to get in about the detail of, but yeah, it's not showing us that we've got less of a problem, I don't think.
Is disengagement more of a problem with alcohol dependency rather than drugs? Other drugs?
That's, in terms of what the data is telling us, I don't know if we know that, Lindsay.
No, we'd have to look into it further.
Sorry, I keep giving you more work.
It's okay.
I did wonder when you said earlier if that meant there would be more scrutiny for me, Dorothy.
I did wonder off the back of that question, Dorothy, looking at 7.2, is that line around the issue around the complexity of needs is a key issue now, and I think that's one for me, is that it's quite a lot of these different indicators. Is do we fully understand the complexity of the need out here? Because when you actually look at the overall figures in terms of drug deaths and alcohol-specific deaths, they're not changing very much. But the work on that standards is really good. It's one of the best in Scotland. So there are things here that are more complex, I think, and that must be quite hard for the staff, I would think. So you don't need to comment to that, but it's an issue that struck me, is just that even with the best work that we're doing here, we're not shifting some of these key figures. Siobhan and then David.
I do think it's the other way around, but David, if you're okay, I'll come in because it's a continuation of what's already been discussed. It was the disengagement that I was really wanting to ask about, and obviously you're going to look into that, and that would be really, I think, quite useful. I'm noticing in 6.6 that, you know, service user disengaged increased by 42%, so that's actually quite a lot. I'm just wondering, when you're looking into that, firstly, you know, when we might get that kind of analysis, but also whether there'll be a look at his connection to deprivation, poverty, and whether there's any connection there.
Yep, I'm going to take that as a really helpful suggestion and take that into the work we do in the pathway as a suggestion, if it's okay, Siobhan. I think that's a good idea. I think inevitably if waits get longer, the level of disengagement increases because there's a window of opportunity, I feel, when people are in the right time and kind of, you know, they've got their motivation up, they're ready to go, and you can lose that window of opportunity. So it's a worry.
David,
Thanks, Jenny.
yeah. Thanks, Siobhan. David, and I think Martin's going to come in after that. David.
Yeah, disengagement is a concern. I had a question mark marked on the report just to try and get an understanding of that. But just looking back at 6.3 and 6.4, am I right to say, is there a correlation there between, when you see, if we just use alcohol treatment at the moment, saying that the number of referrals have dropped, but you know, in the over the year comparative 23-24 to 24-25, but the number of individuals starting treatment has almost increased by the same number, that the number has dropped back from referrals. And the same happens in 6.4, where number of referrals for drug treatment have increased, but number of people starting has dropped. And I think there's a direct correlation there, that the numbers do look very similar for the number of referrals either decreasing, but actual people starting treatment. And that kind of says to me, like as a lay observer, that numbers are kind of flat, and they're just that in the case of alcohol, more people are actually, people are coming effectively off a list of referrals and being treated, but that list hasn't increased, and that may be part of disengagement. Am I looking at that bit too simply?
Jenny, do you want to pick that up?
I was wondering if Lindsay wanted to comment around the numbers just to.
Okay, Lindsay.
We'd have to go and investigate it further. It's probably not something I could sort of speak to sort of off the top of my head. I wouldn't want to be inaccurate in what I was saying. So I'm happy to take that away and look at that in more detail.
Lindsay, please don't. I don't need you to do that. It was more an observation from me, just trying to wonder that. I don't need to have an answer to that. It just seemed to me almost if there is disengagement, and then if there's been such a large increase in disengagement, as they're saying, of 42% there, and it just seemed to be, if referrals, if number of people being treated, starting treatment are increasing, I could understand why referral numbers are dropping, because they're coming off referrals and moving into treatment. That's what I'm trying to get at. Yeah. So no, please don't go and do extra work on that. It's just an observation, really, from my point. Thank you.
I wondered, David, if that can be addressed in the next quarter report, given the number of questions that have been raised in this area, and that can be addressed probably more fully then. Martin.
I think Mark's put his hand back down.
Right, okay.
So I didn't put my hand up.
Is that a question, Martin? I'm not quite
sure. No, I didn't have my hand up at all, so I don't know what happened there.
Oh, I see. Yeah, right. I got you now. Sorry. I think there are some problems online today, from what I can pick up. Right. Thank you very much indeed. As I say, I just go back, and I think that one of the things I did want to highlight for the team, and I think it's quite important for morale, is how well we are working around these MAT standards. And Dave, I think it's a bit like exhortation to the troops, really, that they're actually doing a damn good job. And it's just the complexity and the scale of what we're dealing with here is what we're having to address as well. But let's not forget how well we're doing with these MAT standards.
Yeah, I'll feed that back, Bob. That'll be very much appreciated by the team.
Yeah, I think so. This is a long war of attrition. It really is. Thank you.
Thank you.
And I'd like that to be highlighted in a minute as well, please, if I may. Thank you. Now, do we now move to just accept the recommendations within this report? Thank you. Okay. That now takes us to item 7, which is the Mental Health Services Indicators, Quarter 2. Who's going to lead on this today?
So it's me, Shahida. So I'll start off, and then Jenny will speak about the operational narrative.
Okay, thank you. Shahida, proceed.
Okay. So the data again is based on rolling quarters. So the most recent data is from October 2023 to September 24. Since the last time we reported, we now have updated census data, which shows that Dundee has the second highest rate of people who self-reported that they have a mental health condition in the 2022 census. The highest rate was in the 16-34 age group, and Maryfield and Coldside had the highest rates. So looking at the headline data for mental health, the rate of mental health admissions has increasing trends when you compare it to Q1 22-23. Numbers have now beginning to stabilise across hospital admissions and emergency admissions. There is substantial variations across the LCPP areas, with the most deprived localities having the highest rate of admissions. There are improvements in the rate of mental health bed days for mental health admissions and emergency admissions. And there's also a decreasing trend for the mental health specialities for delayed discharge for mental health. So there has been increase in referrals to psychological therapies, psychology of old age, community-based mental health, and learning disabilities. There's also an increasing trend for the people who are discharged without being seen for psychological therapies, psychiatry of old age and learning disability, and a decrease in trends for those who are discharged without being seen for the community-based mental health teams. So meaning that they're seeing more people. So for the social work mental health teams, there is a decreasing trend in the referrals for both the MHO teams and the community mental health teams. There's an increasing trend in guardianships, emergency detentions remain about the same, and there's an increase in short-term detentions. Okay, that's now pass to Jenny.
Thank you,
Okay.
Shahida. Yeah, absolutely no question. This is a very challenging area to work in at the moment, and you'll be aware that we're in enhanced support measures around psychological therapies. A lot of the work we're undertaking in relation to our mental health model of care is Tayside-wide. So we've been doing a lot of work to develop what new models of care would look like in relation to mental health, and that includes working on personality disorder, complex social needs kind of stuff, neurodevelopmental, ADHD, and the other one, and I've forgotten the first three I told you. Yes, early intervention in psychosis, as a kind of what our future model of care would look like. So we're at a kind of point of thinking about, right, how do we start to implement these? Dundee's been a test site around the early intervention in psychosis, and that's shown some really amazing signs of just turning people off a pathway that would involve multiple inpatient and episodes of care and getting people back into work, back into society. So I can't really commend that work enough in terms of the impact on people. We're now looking with NHS Tayside on a Tayside basis about how we scale that up. We've obviously put aside money from reserves to test out an ADHD pathway, and we're starting to think Tayside-wide around how we implement the rest of this and what the personality disorder model looks like. That's in the process of being finalised. In the meantime, though, you'll see that regardless of offering additional appointments across the whole system, the challenges still remain. Happy to answer, well, I say happy. I will answer any questions on that.
Yeah, this is really tough stuff. This is really hard. Any questions? Dorothy, thank you.
It's not a question, but just an observation. When look at the figures for suicides across Scotland, just shy of 800 in 2023. This is such a difficult topic, and so complex, so complex. Over to you then, Jenny.
Probably not going to manage to sort that on your own, but yeah, it's so difficult.
Dave, this is a tough paper to read, actually, and I'm just reading from not just for Dorothy's reflection, but it seems that the problem is just so enormous that I just don't know how one health and social care partnership can cope with this, frankly. And I'm beginning to look at perhaps there's something much more strategic needs to happen around this work. And that's without going into the referrals relating to learning disability, for example, which is an increasing trend every year. And I believe that Dundee has some of the highest numbers of individuals with learning difficulties in Scotland.
Yeah.
So all of these indicators tell me there's a real malaise across a number of different key areas within Dundee City. And I wonder this needs another kind of fora in many ways to adequately address these issues. Anyway, Dave.
Yeah, no, I'm absolutely right. I mean, I think from the last two papers that we've just kind of gone through there around kind of the drugs and alcohol and the mental health side of things, kind of really sort of illustrates and kind of hammers home the challenges that the city's facing. And you're absolutely right. No, we are part of the response around that, whether it's been the early intervention prevention agenda or kind of actually the service delivery side of things. So as Jenny mentioned, so in terms of mental health, we have got the Tayside approach around that, and we'll work across with our partners around that, and that kind of includes some of the learning disability side as well. But it is from a Dundee perspective, it is a Dundee partnership issue. It's not it's not just about what we do in the IGB and the Health and Social Care Partnership. So and these issues are feature prominently in these discussions around the challenges, because it's there's that the multi-partner effect and what we can do around that. But I think we continue to push that to look for solutions. But again, there might be a case of once we get the the mental health redesign programme in place, test it out, see how it's going, we might have to come back around some other intervention that might be required.
And can do refreshers on the timescale that you're anticipating for that, Dave?
So we should be getting further updates to the IGB over the next couple of meetings. I think we're April for the next update in terms of that kind of whole system change programme. There is obviously a lot of work underway around that. There's the focus on the Strathmartin site, for instance, around learning disabilities. So there are things that are moving around that side. So we'll get another update in April, and then we can, if we feel as an IGB that's not going to go in quick enough, then we can highlight that as back to our partners.
Okay, thank you very much. Any further questions on this paper on mental health services? Okay, thank you. Well, we will note the recommendations within the paper. Thank you so much. That then takes us to item 8, which is unscheduled care. Who's going to lead on this?
Lynn's on.
Yeah. I can lead on that, Lindsay, unless you want to take the lead.
Happy for you to make a start, and I'm happy to answer any questions regarding the data.
Thank you. This relates to our quarterly update on our performance in relation to unscheduled care. Of note, I guess, is our reluctance to use the terminology around delayed discharge, and we've moved very much to all of our work streams being focused on discharge without delay in an attempt to just change that narrative. We note in the report that we have 4 work streams that are focused around discharge without delay this year. First is optimising access, which is focused very much on our urgent care service and creating something quite similar to a flow navigation hub, but within communities, so that we have early access for the more generic services like Scottish Ambulance Service, for instance, that allows early access to try and minimise admission to hospital when it's not required. We have Performance 95, which focuses on enhancing performance around the ED and all of the processes around that. Community urgent care, which links again into optimising access, and our optimising flow work, which really is an extension of the discharge without delay work. So if we move to the charts, we can see that our performance in Dundee, sorry, there's a hand. David, do you want to come in before I continue?
No, sorry, Lynn, Carrie, I just want to be one of the first to make a comment on this when you finish.
Okay.
I think, just you finish your presentation, Lynn. Yeah. Thank you.
Will do. All right, so I'm not going to go over every chart, but I think if we look at charts 1 to 4, we can see that the Dundee performance continues to be significantly better than the Scottish average, both in terms of the numbers of delay, the numbers of bed days lost, and it's an improving picture in Dundee. So the chart in chart 1 shows that we were 6th on that particular snapshot in Scotland. We're consistently in the top 10 and actually quite regularly on a weekly basis. That's unverified data, but regularly in the top 1 or 2 performing partnerships. Similarly, both for our complex delays, our non-complex delays, our younger and older adults, we are seeing an improving picture in terms of the number of bed days lost and the number of delays for all of those categories. The lengthier delay median tends and continues to be in the younger category, and that reflects the complexity around particularly our general adult psychiatry and learning disability patients. If we move to chart 6, we can see the ongoing correlation between the excellent performance and improvement work that's been ongoing in social care services and how that links directly to our performance against delayed discharge. In December of this year, notably in the middle of winter, which is always a very pressurised time for hospital services, we actually declared no delays in our acute hospital in December. Just of note in relation to the presentation that Shahida did earlier, that where we mentioned delayed discharge, the discharge without delay work is primarily focused on older, frail adults and focuses on trying to either retain them in their own home or discharge them back to their own home as quickly as possible to avoid the deconditioning and the added dependence that is layered on by prolonged stays in hospital. So just important to note that if social care slows down, we are likely to see actually over time an increased spend because we will have more deconditioned adults who will require longer stays in hospital and bigger packages of care. And that's, I guess, the complex financial dilemma that we face because of the proposed cuts. You can see in chart 8, figure 8, that we continue to discharge 98.5% of all of our patients in Tayside without any delay. And just again, an update at the end of the report about all of the various or some of the various improvement measures that we're taking to maintain that performance. Thank you.
Thank you. And I think that latter part, has been picked up by First Minister as well as the Cabinet Secretary for Health. Thank you.
We actually met with the First Minister on Friday, and he was extremely receptive to that idea.
Exactly. These are very positive figures. Thank you by comparison elsewhere. Dorothy and then David.
I think David's been waiting longer than I have.
Oh, well, in that case, David, you've been waiting longer.
Thank you. I was going to say this, it's Dorothy, but the same as me, I'd imagine. It's bringing a little bit of politics into this, but I think too often NHS Tayside and the health and social care partnerships are receive negative press, and I think bearing in mind that we have the press watching or engaging with us today, I would encourage them to look thoroughly at all points from 5.2 through to 8.0 to show how well the good news is here, how well we are performing. And Lynn, I'm delighted to hear you mention that it's now should be regarded as delays without, discharge without delay, because it actually, when we're outperforming in Dundee, the standards required and being the best in Scotland really here, that should be being shouted from the rooftops. I know we're not getting enough good publicity and media coverage to show how hard people are working and how well plans and strategy is succeeding here. So it's really, as Bob said, there's enough things to concern us in these reports, which are of genuine concern. But when we're doing well and we're succeeding, we should be equally applauding the hard work that's being done, the results that are coming from all of that. And I hope that is picked up in the press. Thank you.
Well, I'm glad I took you first then, David. Thank you very much. Dorothy.
I'm going to say something very similar because this is a real success story, a great achievement to bring these numbers down to 0 bed days lost in acute hospitals in December 2020, early December 2024. That is amazing. And well done to everyone in the team who's been involved in this work. We can do it when we set our minds to it. Unfortunately, we are looking at a difficult financial landscape, so we might not be able to keep this, but this is excellent work. So well done, everybody.
I think we should leave on that note, don't you? Okay, thank you so much, both of you, for presenting this information. And as I say, it's a very positive story to tell here, and I hope that that's recognised. And I think, Dave, that's something that I just reflect. We were talking about communication with the public, and I think there's something about how we actually do this, rather than be reactive to it. Then I think we could go out there and say something positive, as well as explain the processes of why this happens here. It's not an accident. There's a lot of work goes into that, and resource. So thank you so much. And I presume we're accepting the recommendations. So I'm now going to move on to the next one, which is item 9, the Strategic Risk Register update.
I'm going to take that one this morning, Bob. In Claire's absence, she's prepared the report. So this is the routine update on the Strategic Risk Register, and I'm just going to focus on a small number of changes since the last time it was reported to you. So just to highlight from the report then, that the risk that relates to restrictions on public sector funding has been increased to a new score of 25. I don't think that will be any surprise to anybody, or you need much context for that, given all the discussions around the challenges of the budget position. There has also been a new risk added in relation to national insurance contributions, employers' national insurance contributions. And in regard to that risk, just to point out that the main area of concern around that is particularly in relation to the impact that may have on third sector services, of course, which make up a large proportion of the providers of health and social care services locally. And we're continuing to look at the controls round about that and speak to our third sector partners about the potential impacts for them. And the only other thing I was going to highlight, that there is a risk on the register in relation to the National Care Service, which is scored at a 20 at the moment. But clearly, I think we'll probably need to reflect on that risk, given the recent announcements in Parliament regarding the direction of travel for that. So I would anticipate that we'll do that before the next report comes back to the IGB and consider any changes around either the risk scoring or the kind of mitigating controls round about that. And that's all I wanted to highlight, Bob.
Thanks very much indeed. When I looked at this particular Strategic Risk Register, I wondered, well, what kind of mitigations could we do around national insurance, for example? So I've always been a bit perplexed by some of those risks, which are overarching ones, you know, like the cost of living. The NCS has changed quite dramatically now as in recent days. So I kind of struggle a bit with this side of it. Public sector funding, there's not a lot we can do about this as Health and Social Care Partnership. So in many ways, we're just noting these risks as much as anything. So I kind of slightly struggle with this paper because I can't see what mitigations we can do as an HSCP here. But anyway, maybe Dave, can you highlight what we can do about these things?
No, it's a really good point, and I think, you know, a lot from the Strategic Risk Register, because it's the strategic kind of side of things, it takes into account the external factors, and some of which, as you say, we have no ability to influence. So I think the key thing for us is what we can do to try and mitigate within the partnership. So, you know, when it comes to the budget and the restrictions of public sector funding, it's around, well, what transformation, what change can we make? What efficiencies can we put in place to kind of make sure that, okay, we're going to be hit and hit hard, but, you know, we try and kind of lessen the impact to it whenever possible. And similarly, you know, things like some of the workforce issues and the challenges around that. We've got kind of obviously the audit report around workforce planning, for instance. So there's kind of how we kind of what we do around workforce planning and the likes around that. So, but no, a really kind of valid point, but. We can try and control what we can control, but acknowledge the risks that we can't control.
I certainly think that I'm not seeing any questions at the moment, but certainly the one around national insurance, for example, this will have an enormous impact, as already been highlighted by Catherine, on the third sector. And are we likely to get any response through Scottish Government about what negotiations are actually happening? Is there going to be any change in this? It's a massive issue.
Yeah, I'm aware that there are discussions ongoing with providers and Scottish Government, but in terms of an outcome and a timing of the outcome, I'm not clear when that's going to be. Obviously, from our side of things, we need to kind of consider it for our budget. perspective in terms of kind of some of the actions we might need to kind of take around that. But so we'll continue to kind of pick up through the chief officers, the national chief officers group around this as an issue, because it is an area of real concern.
Thank you. And I'm going to finish up on this one. I'll take Siobhan and then Martin. Siobhan.
Thank you. Just following on actually from the ENICS discussion. There has been obviously some discussion in terms of mitigation that might be coming via Westminster, but obviously that looks like it's not going to be 100% mitigation. I suppose my question is, how much of that mitigation are you taking into account in terms of the finances?
So in terms of from
the
an
ENICS,
NHS perspective, so from an NHS perspective, the assumption is that we will receive from Scottish Government the full funding for national insurance. That's the planning assumption we've been told to take. From a local authority perspective, that will be kind of very much reliant on the council's budget setting at the end of next month, in terms of what might kind of flow through from that through into the partnership in terms of overall funding. And then the big question mark still outstanding for us is that third sector and where that kind of lies. So if there's additional funding that is made available, then obviously that's good news, and we can bring that through. But at the moment, from our budget purposes, we're assuming that there's no additional funding for the third sector coming through for national insurance, just because we've not had any kind of real kind of confirmation or otherwise on that.
So that's where the pressure may lie then.
I think Arlene in a minute, can we highlight that, please? Thank you. Martin.
Thank you. Just a very quick question. One I've asked repeatedly in the past, relating to access to the risk register. Now, I know that was something that's been looked at for members of the IDB and for the PAC, and I just want to know, have we had any progress on that?
Dave?
Yeah, Mark, we'll pick that up again, because I think, to be fair, I think that's probably kind of slipped off our kind of immediate priorities just now, because of some of the other system changes that have happened in the council and NHS. So we'll pick that back up again and kind of bring that back up as a priority.
Okay, thank you very much.
Okay, can we therefore note the recommendations within the report? I think the conversation has highlighted the key areas that were needing to be addressed. So what I'd like to do now is to take a break, and if we could come back, say roughly about 1:15. Okay. Thank you. Okay then, welcome back. Let's now move on to the next paper, which is item 10, which is the internal audit report workforce. Dave, were you leading on this?
Yes, I'll just do the introduction. I'll pass on to Jocelyn from Internal Audit to kind of take us through the report. So this is one of our substantive reports through the audit process that within our audit plan. I'm pleased to see this one coming. Around it kind of links in with what we just discussed previously around the risk side of things and kind of workforce. Although this is kind of primarily focused on the development of the workforce plan itself. So there's a number of kind of recommendations within and findings within the report, which I'll let Jocelyn kind of go through. I think from my perspective, I find it kind of as I do with all these audit reports kind of really useful, because they do give us a focus for improvement and development. So while there are that number of recommendations, we've kind of reviewed those and have a number of management actions in response to those. So I'll not say any more. I'll pass on to Jocelyn to provide a bit more overview.
Thanks, Dave. Oh, thank you, Bob. Yeah, so this report provides limited assurance, and as Dave said, we made some recommendations. We made 3 significant and 2 moderately risk assessed recommendations. Management have agreed actions to address these, and they're all due for completion at various times, but all by the end of April this year. So that's quite soon. So there's work to be done there, and they will of course be picked up through the governance action plan. So the main findings, the main points from the audit are summarised in the cover paper. And just to really kind of briefly go through those, the first one's the requirement to model service demand to understand the required workforce. We've talked about the need to further develop the workforce strategic risk register. There's also a need to develop the workforce action plan as a monitoring tool so that can provide assurance that the most important areas are being progressed. And we made 2 points around the work of the workforce planning group. Firstly, about formalising the work of that group, and secondly, ensuring clear linkage to the mitigation of workforce risks and controls. So as I said, we have agreed actions. The first agreed action is that the workforce planning data subgroup will review the approach to service demand and workforce modelling. Now that approach will be based on the data that's available locally through the DH&SCP, from the partner bodies and any kind of relevant national data. And the workforce planning action plan will be updated to reflect that approach. There is an acknowledgement that approach will have limitations within the available capacity, but I think it'll be really important to see that one going forward. For me, that's the key recommendation in this report, and this action is really the most important aspect. We also have agreement that the Workforce Strategic Risk Register will be revised and updated, and that will mean that it will include risk scores, current and planned mitigating controls, and that will be consistent with the Strategic Risk Register format. So that's a welcome development. We also have agreement that the Workforce Action Plan will be revised and updated, and as I said, that will really help with that monitoring. And that update will also include any outstanding feedback from Scottish Government that hasn't already been included in there. And as I said, on the Workforce Planning Group, we're going to get terms of reference developed to formalise the work of the group, and that will really make sure that there's no gaps or any duplication with the work of other groups. So really just pinning down the exact role and remit of that group. And the final point is ensuring that assurance is provided over the effectiveness of the arrangements to mitigate those workforce risks. So really that link between risk and performance. And that group's agenda will link more closely to the risks, and that will be reflected in their agenda planner. So that's all I really wanted to point out. As I say, I'm pleased that we've got those recommendations. The responses to those recommendations in place, and we will of course continue to monitor them. And I'm happy to take any questions on the report. Thank you.
And thanks very much indeed, Jocelyn. Just a point in terms of that process between yourself and the Chief Officer team. In terms of setting the timescales, as you say, a number will be completed by April. And do you formally sign that off as well, or do you just take that as what they think it will be in those timescales? How does that work?
That would form part of the discussion at the exit meeting stage whenever we're finalising the report. So we always say, please make sure that the timescales are achievable. And if we believe them not to be achievable, we would go back and say, why don't we have a rethink? Let's look at extending these. But I mean, I think Dave wants to come in, but I think in this instance, we were content that those timescales were achievable.
Okay, thank you so much indeed. And Dave?
Yeah, no, just to follow, I think we've been guilty previously of kind of being too ambitious in terms of some of our expected kind of action completion dates over the years. I think so. Well, it looks like some of these are quite ambitious. I think we're quite comfortable that some of the actions that are required are either already kind of underway or are things that are not significantly kind of challenging for us to deliver on, that we would kind of need to push those back. So. As Jocelyn said, I mean, these will be more picked up through the governance action plan as well in terms of actions for us to kind of revisit. So if these timescales slip from a PAC perspective, you'll have visibility and be able to kind of challenge us on those items that have slipped.
Yeah, thanks very much. It was really around the ambitious bit that I was interested in. Dorothy.
Thank you, Jocelyn. I note limited assurance, which is of course concerning, But I see there's an action plan, and I hear you talking about an action plan, and you've mentioned the governance action plan. Will this action plan be reported to the PAC through the governance action plan? Is that how that will work?
Yes, yep, that will be reported there.
Okay, that's fine. Thank you.
Catherine.
I think in terms of timescales, it's probably also helpful for the Performance Audit Committee to be aware that there's a requirement for the Health and Social Care Partnership to submit a revised workforce plan to the Scottish Government by the 17th of March. So there's actually a nice alignment of timescales around about these audit actions and that piece of work that's required. So we've wrapped those up together and started to progress the revision of the workforce plan to address all the audit actions, but also the requirements from the Scottish Government, including looking at the self-assessment that is referred to in the audit report as well. So we've got a clear plan about how we're going to do that, and we'll submit to the Scottish Government on the 17th of March as a draft, and our intention would be to bring the workforce plan back then to the IGB in the April meeting. So you will see it there as well as seeing it through the Governance Action Plan. So I think that just because of the timing of those two, the report and the national requirement, I think there'll actually be quite a bit of visibility for you in terms of being able to see that that's been followed through.
Thank you very much indeed. If there are no further questions, I'm going to move to, do we accept the recommendations within the report? Thank you. And that now takes us on to the actual Governance Action Plan Progress Report. Who's leading on this? Are you going to lead on this, Jocelyn?
Back to me for this one, Bob. Again, in Claire's absence, because Claire is the person who has to do the complicated task of constructing this report. Again, I'll just focus on the changes since the last report came to you. So there's 3 actions that have now been assessed as being completed. All of those actually relate to the completion of the work we've been doing around the Governance Action Plan, the revision of the plan and the reinstatement of regular reporting. And now we are back into a regular reporting cycle. There's the 3 actions that are associated with that are now marked as complete. There's obviously a number of ongoing actions. There's 6 of those where there's been progress since the last report to PAC, which was just in November last year. So that includes actions where there's been progress around the IGB's risk profile, and most of that follows on from the risk briefing that we held with IGB members or development session towards the end of last year. And there's also been some progress, significant progress in terms of a previous internal audit report about provider sustainability and how we monitor financial returns from them as well. So those are the 6 with kind of more substantial progress. I think about 25% improvement in the progress round about those ones. And we've already covered the fact that just to note that the new actions from the workforce audit will be added. So you'll see those appear from the next report to PAC as well. But I'll leave it at that in terms of highlights, and happy to answer any questions that I can.
Thanks very much. Dorothy?
I don't have a question, Catherine, but I do want to say that the IGB development sessions that have been organised over the last few months have been extremely helpful. I've really enjoyed them. Very useful sessions, and long may they continue.
Thanks, Dorothy. We'll pass that on to the folk who've been involved in planning and delivery.
Yeah, I would agree with Dorothy. I think they add a lot of value to the work we do to assist in understanding these reports much more. Thank you so much indeed. Any further questions around this item? If not, we'll just move to accept the recommendations. Thank you. And that takes us to item 12, which is the IJV Internal Audit Plan Progress Report.
So again, I'll maybe just take a couple of words and pass on to Jocelyn on this one. So again, this is a regular report, obviously kind of sets out the internal audit plan progress. Just one thing I was wanting to kind of draw your attention to, because I know it's something that we have discussed at the wider IGB numerous times. So we've got the audit sharing kind of element of a report where we've got the NHS side reports and also the Dundee City Council internal audit reports that are of relevance or are deemed to have relevance to the IGB and Health and Social Care Partnership. There is the report under Dundee City Council around absence management and staff wellbeing. So you kind of note there's been limited assurance provided around that, but a kind of number of key findings that from a council perspective will be kind of worked through. And obviously from a health and social care partnership, we will be kind of part of that in terms of the kind of solutions and the responses around that. So I just thought that was one that was kind of particularly pertinent to some of our more recent discussions. But again, I'll pass over to Jocelyn for anything else she wants to add.
Jocelyn.
Okay, thanks, Bob. Thanks, Dave. Yep, so as Dave said, this is the progress report. It sets out the completion of the 23-24 plan with the finalisation of that workforce audit that we've just considered, and progress on the 24-25 plan. I just wanted to touch on section 4 of the cover paper, which talks about the external quality assessment of internal audit. That exercise is now complete. So thank you to anyone who was involved in that, who was talked to as part of that process. Just to say that we now have a draft report, and we'll be clearing that report with the assessors from the Chartered Institute of Internal Auditors, and then we will provide assurance back to the committee on our compliance with the new global internal audit standards that come in the 1st of April. So that's an ongoing process. We do have several recommendations within that EQA, so that may mean that we have some changes to, for example, our internal audit charter, to make sure we're compliant with the new standards, but we will keep you up to date on where we're getting to with that improvement plan. So just in terms of progress set out at Appendix 1 for 23-24 and 24-25, I just highlight that the next audit that we're going to be doing is the internal control evaluation, and that's going to start at the beginning of February, so really quite soon. And as members are aware, that's the overall governance review of all areas of governance that aims to provide early warning of any issues to be addressed before year end. So that's next on our list. Our council colleagues are going to be conducting the audit on lead partner arrangements, and that's at the initial planning stages at the moment. So definitely the ICE coming next, and then the lead partner audit after that. And Dave touched on the reports from partners, so I won't say any more about those, but I'm happy to take any questions on the NHS Tayside report, and if there are any questions on the Dundee City Council reports, I'm happy to take those back to colleagues within that team. And I think that's all I wanted to point out. Thank you.
Thank you very much indeed, Jocelyn. Questions for Jocelyn or Dave? David.
It's not really a question, Bob, but I don't want to sit quiet on this, but I know I continually raise the whole thing about absence management and sickness absences and things, and it's quite clear that the one of the findings here is a major part of that. It's a big part of this paper, and I think it's right that we draw attention to that, because there are a number of areas in that where methodology is not being followed, and so I think it's worthy of note, and that has to have substantial improvement, because it has huge knock-on effects for viability and ongoing work within the IGB and health and social care partnerships.
I dare say that's probably been one of the most notable issues, Dave. I don't think we need to have a response to that necessarily, because it's probably, yeah, thank you. Any further questions before I move to close this item? Okay, thank you so much. And we note to recommendations, and particularly the one about the workforce. Thank you so much indeed. Jocelyn, thank you for coming along today. Appreciate that. And that takes us to the attendance list for information. If there are any comments or amendments to that, please let us know. And the date of the next meeting will be on Wednesday, the 21st of May.
Good.
And by that time, we'll know what our budgetary situation is.
Yeah.
Thank you so much. Okay, thank you.
Thanks all.